Welcome to this program entitled New and Emerging Treatment Options for Hematological Malignancies. My name is Dr. Joseph McHale. I'm a professor at the Translational Genomics Research Institute, and I'll be sharing with you shortly about multiple myeloma. We also have two outstanding other faculty that have joined us for this program. Dr. Fred Hagemeister will be speaking about lymphoma, and Dr. Courtney DiNardo will be covering the topic of acute myeloid leukemia. So the objectives for this program, including outlining the Bcma targeted therapies for multiple myeloma, citing new and emerging treatment options for Hodgkin's lymphoma and diffuse large B-cell lymphoma, and also assessing the cytogenetic and molecular alterations in the diagnosis of patients and novel therapies for acute myeloid leukemia. So as noted, to cover that, I will have the responsibility of reviewing the Bcma target therapies for myeloma. Dr. Hagemeister will cover Hodgkin's and diffuse large B-cell lymphoma, and Dr. DiNardo will speak to us about acute myeloid leukemia. So let's dive in to multiple myeloma, which I dare to say is the most interesting of these topics, but my bias is clear that I am a myeloma physician. And we're going to talk about Bcma, or B-cell maturation antigen, targeted therapies for multiple myeloma. My conflicts are listed here for whom I have served as a consultant. So just to sort of step back in the balcony for a moment and look at where we are, I've had the privilege of being involved in myeloma for over 20 years. I don't know if there has been a more exciting year than this year for the new drug development within this field. And not just drugs, actually, diagnostic tools and screening studies and health disparities. There's so much going on in the myeloma space. But for our purposes today, we're going to narrow our focus to Bcma-directed therapies. So recently, we've had several new agents approved: selinexor, isatuximab in combination with pomalidomide, belantamab mafodotin, melphalan-flufenamide, which unfortunately has now been removed for the market unless patients are continuing to be on it, and then the first CAR T-cell therapy for myeloma, ide-cel. We have new indications using daratumumab subcutaneously, combining carfilzomib and daratumumab, bortezomib with selinexor, and indeed isatuximab with carfilzomib. So this is what has already been approved. And we're looking into the coming year, and we anticipate that we may have another CAR T-cell therapy and indeed a whole series of bispecifics along with multiple other agents. What I've put in red here are the ones that are directed towards Bcma, a relatively new target for us in multiple myeloma. Historically, we've obviously focused a lot of our treatments in CD38 therapies, as we've seen with daratumumab and isatuximab. And so as we move forward throughout this discussion today, we're going to be focusing our thoughts a little bit on Bcma-directed therapies, although I'll make a few comments that there will be other targets that we're going to be exploring even more so in the future. Where there is such a great need right now in multiple myeloma is triple class refractory disease, using those three major classes as our backdrop of proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies. Most patients will be exposed to these within their first few lines of therapy in multiple myeloma, and unfortunately ultimately become resistant to most of the drugs within those classes. Often we think of it as penta-refractory, 2 proteasome inhibitors, 2 immunomodulatory drugs, and at least 1 CD38 antibody. And in that situation, we do have some options, which include selinexor, which include belantamab, and indeed CAR T-cell therapy. And so we'll review some of the data regarding belantamab because it's Bcma-directed and the ide-cel product. But then I'm also going to preview for you some upcoming phenomena, both in CAR Ts and in bispecifics, that are specifically Bcma-directed. We won't have time today to talk about other novel agents like iberdomide and TAC573 and others that are coming in this space. There are so many more, of course, but we'll focus obviously within Bcma. So why Bcma? Well, first of all, Bcma is prolifically expressed on nearly all myeloma cells. And not only so, we know that it is a really important antigen on the surface of myeloma cells that has connections inside, as you can see through this figure, with signal transduction that really affects the growth and survival of that cell and even the maturation of that cell, including class switching. So it is a very natural target to be able to hook onto, as it were. And although it goes beyond the scope of our discussion today, we are beginning to see that we can actually treat people with a BCMA-directed therapy and then use a different BCMA-directed therapy again in the future. And not something we typically do with other targets. That there really is a very small fraction of patients who develop true BCMA resistance, probably less than 5%, as we understand this target more. So in many ways, it's an ideal target. Not only is it prolifically expressed, it's connected to cells growth and survival, but it also seems to remain to a certain degree accessible even after a patient has had a BCMA-directed therapy. Well, what was the first FDA-approved agent that was BCMA-directed? Was belantamab mafodotin. This is a very interesting drug because it's really not just an antibody, a monoclonal antibody directed towards BCMA. It also is conjugated with a toxin, that auristatin F, as you see here. Then that toxin, that mafodotin, can get engulfed into the cell and help with cell destruction. So it really is a bimodal way of treating a patient where the antibody will trigger the natural humoral mechanisms of antibody-dependent cellular toxicity, et cetera, but also now have a toxin that gets dropped into the cell. And this was evaluated through the DREAM2 study, which looked at two different dosing strategies for belantamab, be it 2.5 or 3.4 milligrams per kilogram, given every 3 weeks. And I'm just giving you the highlights here, that the response rate that we saw in the dose that's gone ahead, that lower of the two doses, was 31% in patients who were triple class exposed, if not triple class refractory. Interestingly, not only did we see this response rate, we saw that a significant fraction of over majority of patients had a deeper than very good partial remission response. So this is quite striking for us in the myeloma space, where most of the drugs we've had in this space have about that 25, 26% response rate, to see that with this single agent that's given once every 3 weeks. It's generally speaking very well tolerated with respect to the infusion and cytopenias. The challenge with this drug is around 70% of patients will experience a keratopathy, where we believe the toxin may accumulate in the cornea, and this can affect people's visual symptoms like blurry vision or dry eyes, and affect their visual acuity. And so there is a very sophisticated REMS program where patients must be seen by an eye specialist, be it an ophthalmologist or optometrist, before each dose. And if the keratopathy goes beyond grade 1, the drug has to be held until it's given again. We're exploring different dosing strategies to reduce this risk of keratopathy. The second area where we have seen BCMA activity or BCMA approval by the FDA was in CAR T-cell therapy. You're likely familiar with this, so I won't go through this in much detail, but we collect T-cells from patients, and then we do the manufacturing process where we can indeed ensure that these CAR-Ts, our CARs, or chimeric antigen receptors, are adhered to these T cells. We multiply them in the lab by expanding them, and then give them back to the patient after we've given the patient a little bit of lymphodepleting chemotherapy. The first of these products in myeloma is BCMA directed in the ide-cel product, where you can see here that there's that transduced CAR lentiviral vector that is going to then allow this to adhere to the BCMA when given back to the patient, and then trigger T-cell activation and even other T-cells in the area to be activated. So this binding of these CARs to the BCMA is the mechanism by which it can help destroy the myeloma cells. We've seen this, of course, in lymphomas and leukemias, and now we're seeing it in multiple myeloma. This led to the approval of ide-cel, as you see here, and its publication in the New England Journal earlier this year, where we saw really, frankly, unprecedented response rates in an FDA-approved agent. As I mentioned before, in single agents, we had seen sort of 25 to 30% response rate, and here we are over 70%, if not over 80% at that dose of 450 times 10 to the 6. So first of all, an efficacy response that really was quite striking for most of us in multiple myeloma, knowing that these were patients who were very heavily pretreated, median of 4 to 5 prior lines of therapy. Most of them were triple class exposed, if not refractory, and so really quite impressive. Not only so, it was quite durable. These are patients who sadly maybe have an expected survival of 6 to 9 months, and here we have a progression-free survival of just under 9 months and an overall survival of 19 months. So it does tell us that there are options for patients even after they progress post-CAR T cell. Now, the majority of patients do experience a cytokine release syndrome. There are other potential neurological events and other hematological toxicities that have to be looked for. Obviously, this is done currently as an inpatient for at least a period of time. But thankfully, when it comes to the cytokine release syndrome, the overwhelming majority of these are lower grade, not so much grade 3 and 4, but this has to be carefully managed. Obviously, we're learning a lot about cytokine release syndrome and getting better at managing it, but it is something that we have to consider in this process. So CAR T cell therapy is already approved. And as we look to the future, we are going to see a whole series of other CAR Ts that are coming. I'm just going to briefly show to you, as we're in the theme of BCMA today, that there may be a way to boost the BCMA with a gamma secretase inhibitor, sort of an interesting concept to more prolifically express the target on the myeloma cells. But the other area of BCMA activity that has really engendered a tremendous amount of interest are these bispecific agents, and I'll come to those shortly, but these are agents that really are called bispecific because they have two arms. Some of them are even trispecific, but basically where on one arm it is hooking to the myeloma cell by virtue of a BCMA, but with the other it is directly engaging a T cell, for now T cells. In the future we may be using other cells, as we're investigating that in studies now, but where it directly engages the T cell. Obviously, the advantage here is that we don't require the apheresis and collecting of a patient's T cells and the manufacturing, and that's not always 100%, of course, and then 4 or 5 weeks later giving it back to the patient. Here, it's kind of an off-the-shelf T cell approach, as it were, where we can give this directly to patients. And we have a whole series of bispecifics, and I've only listed the ones that are BCMA directed. There are others that have different targets that I'm going to mention towards the end. But time wouldn't permit me to go through each of these today, but I will highlight the first of them, Taclistamab, as it is really the first one that we anticipate that we may see approval in the not so distant future. And then lastly, with the antibody drug conjugates that we already have, or the one that we have with belantamab mafodotin, we're now starting to explore its ability to be combined with other agents. And again, this is something that we'll learn a lot more about over the coming years. So what is next for CAR T cell therapy? Well, at the annual American Society of Hematology meeting 2021, this was a very exciting abstract for us to see presented, where we saw the updates of this CARTITUDE-1 study of the next CAR T cell therapy that we anticipate being approved. The previous one was ide-cel. This one is cilta-cel, or ciltacabtagene autoleucel. You can see why we call it a cilta-cel, which was a BCMA-directed chimeric antigen receptor in patients with quite heavily relapsed multiple myeloma. Indeed, these patients were very heavily relapsed. And again, as I noted, this is a drug that we can produce that will ultimately have BCMA as its target. And so we had seen an earlier update in the study at about 12 months, and now at a 2-year follow-up is what was presented most recently. And again, I've already talked you through the process where patients have their T cells collected. They may require bridging therapy in the interim because they'll wait about 4 weeks. And then 5 days before their reinfusion with these new T cells, they're given doses of cyclophosphamide and fludarabine to lymphodeplete them and prepare them for it. You can see that the median administered dose here was about 0.71 times 10 to the 6 with a range of 0.5 to 0.95. And really what sort of was almost jaw-dropping, frankly, was this 98% response rate. So 95 out of 97 patients responded, of which we see 2/3 of them at median 1-year follow-up, and at 2 years follow-up, 83% of them achieving stringent complete remission. So again, these are sort of unprecedented numbers for us. We were quite excited to see numbers up in the 70s, if not even the 80s, with ide-cel. Now we're over 95% response rate, something that again we're really quite shocked by. Not only so, the median time to first response, as you see here, is 1 month. So this happens quite quickly. Understandably, this is a one and done therapy. So from a patient's perspective, with their own quality of life considerations, getting one treatment, albeit relatively intense, giving one treatment and then being able to be off treatment for a long period of time is really quite encouraging. Furthermore, what I found particularly encouraging in this was not just that incredibly deep response, but the durability of it. We saw with our previous CAR T a PFS of about 9 months and overall survival about 19 months. Well, the 2-year PFS has still not been reached, or the median PFS has not been reached at 2 years. So the 2 years PFS is 71%. As you can see in this, if we look at those patients that achieved a stringent complete remission. But even we just look at all of patients, we still haven't achieved a median PFS where it's 60% at 2 years. And furthermore, for the overall survival, and again, it's still a bit early and we don't want to draw final conclusions, but again, the 2-year overall survival is 74%, with, of course, the median overall survival not reached yet. So these are patients who, sadly have an expected survival of maybe 6 to 9 months. And now here we're seeing that their median progression-free survival is over 2 years. So that's really, again, I think important for us as we look forward. So they concluded that, they continued to have a very deep response. I didn't spend much time on the safety profile. There had been some concerns about maybe the neurological effects of this, but there have been no neurological cases per se detected. That this is, generally speaking, reversible and manageable, as is much of the cytokine release syndrome that we also see with this. I mentioned that one of the areas of research for BCMA is to see, can we, if you will, increase BCMA expression? And Dr. Cowan recently presented this at ASH as well, looking at using a gamma secretase inhibitor to increase this. And because the gamma secretase is part of the cleaving process of the BCMA from plasma cells, then maybe if we could inhibit that snipping, as you see here with its scissors, that may be able to improve outcomes in patients. And so, although the work is relatively preliminary, they did seem to show that this was a feasible concept. Obviously, the clinical sequelae of it have to be seen more fully, but I think this is an interesting option, especially if we are going to be using multiple BCMA-directed therapies, that this may be an opportunity in the future to enhance the activity of our BCMA-directed products by having GSI on board. I've mentioned already bispecific therapy. This is a very attractive process to be able to engage T cells without the apheresis. And when I look at the field in general, we are seeing, like we were in the early days of CAR T, we're seeing that we're getting better at this, that the toxicity is going down. And we're seeing impressive response rates, maybe not to the level of CAR T, but with an off-the-shelf-like approach, we're still doubling the typical response rates that we saw with single agents of 25 and 30%, so that now we're seeing response rates really in the range of 50, 60, 70% in general across all of these bispecifics, of which I'm just going to highlight one in just a moment. That being said, there is still a risk of cytokine release syndrome, especially for that first dose. And so that is why at present, all patients on these studies are admitted for at least their first dose. And this may reduce the ability to directly give it to the community, unless, of course, and I think part of the strategy should be that we have to educate the community about CRS. Thankfully, the grade of CRS with bispecifics is mostly grade 1 and some grade 2, and almost no grade 3. Grade 3 is a big jump from grade 2 with respect to managing a patient with CRS. So it's quite possible that we can do this even in outpatient clinics, although I think with time we have to continue to be better at it and prevent it, let alone just manage it. And as I sort of indicated earlier, there may be opportunities to do this by engaging not just T cells, but other cells like natural killer cells that seem to invoke less CRS. And so if we could get the same effect with less CRS, that might be very attractive to the community. So although there have been many bispecifics already, and sometimes I always think of it as this horse race where different ones are leading at different points, I think the one that we're likely going to see cross the finish line to approval first is this drug, Taclistamab, which was also just recently presented at the ASH meeting. So again, this is a bispecific antibody, as you can see here, that is directed towards the BCMA on the myeloma cell and the CD3 on the T cell that will engage the T cells to come and help destroy the myeloma cell, as you see here. And quite impressive, with a doubling of what we've seen with antibody drug conjugates, for example, 62% response rate. You can see that, again, the majority of them have achieved a VGPR or greater. And depending on how we measure it, about a quarter at least of patients with a threshold of 10 to the minus 5 will achieve a MRD negativity. Now, of course, this comes at some cost, as I indicated before. It's not that these drugs have no cytokine release syndrome. In this case, we saw that there were, majority 71% of patients, although half of them had just experienced a grade 1 toxicity, and the other 21% had experienced grade 2. There was one patient with grade 3. And so I think as we learn a little bit more to manage cytokine release syndrome by giving prophylactic, potentially tocilizumab and steroids, we may be able to bring this number down, but it is something that for the short term will likely require still admission to hospital. So they concluded that, this BCMA directed therapy has a 62% response rate, that we can manage most of these events, including the CRS and the neurological events like the ICANS events. But obviously further study is warranted, and further pivotal trials will be conducted in the future. So as I try to put this into this morass of huge changes we've seen in multiple myeloma. We've had proteasome inhibitors, immunomodulatory drugs, monoclonal antibodies for a number of years. We've added nuclear transport inhibitors, antibody drug conjugates directed towards BCMA, and indeed now a CAR T cell therapy for BCMA. Well, we're surely not done yet. This figure doesn't capture everything by any means, but it looks in red where we've been for a long time, and then in green what we've recently added, and in purple along the bottom you will see what we will likely be adding in the not so distant future as we move in frontline myeloma potentially to quadruplets with daratumumab or isatuximab, as we potentially deepen our post-transplant consolidations with more intense maintenance therapies where we may be adding other drugs to lenalidomide, such as daratumumab or carfilzomib. And then as we've been focusing today in that rescue space, that we're almost definitely going to see more CAR T cell therapies, such as the cilta-cel that I described today, likely several bispecific antibodies. And as noted, not just those directed towards BCMA. We've identified several other targets with bispecific therapies, specifically GPRC5D and FCRH5. I know sometimes it sounds like I'm reading someone's license plate, but these are other targets that we know are heavily expressed in multiple myeloma that we will likely see. And indeed, we already have a bispecific for GPRC5D and talquetamab, and a bispecific for that can target FCRH5 in the form of cevostamab. So I think it's very exciting to see that there are so many more options coming to our patients that can help provide them deep and durable responses as we go forward. There's no doubt that BCMA is going to be a centerpiece of this going forward. And as these are rapidly changing, it'll be important for us as clinicians to keep up with this and provide our options for patients. Lastly, one of the things I think is fascinating is, as we typically see with a chart like this, that although these drugs are typically used at the very end after everything else has been tried, we now have several studies bringing these BCMA therapies, in particular with CAR T-cell therapies, bringing them earlier in the disease course at 1 to 3 prior lines of therapy, if not even at frontline therapy. Some trials now are evaluating after induction therapy going to CAR T versus the traditional going to autologous stem cell transplant. So those are part of the things that will likely be a big part of our future. Well, thank you very much for participating in this today. I trust it's been helpful to you in what you can do now for your patient, but also in what's coming in the near and the further future as we continue to increase our options for patients and leverage the BCMA target for the benefit of our patients.
Hello, this is Rick Hagemeister from MD Anderson Cancer Center, and today I'm going to review the ASH meeting from 2021. This was a really important meeting for many different reasons, not only for aggressive lymphomas in relapse, but also for frontline therapy. And there were a lot of new agents that were discussed, which I would like to go over today. There are my disclosures. First of all, I would like to discuss Hodgkin lymphoma and immunoconjugates that have been discussed and were discussed within the last year as well at meetings and in various manuscripts. First of all, I'm going to just go over the negative predictive value and positive predictive value of endotherapy PET CTs for various lymphomas. There have been a number of big publications, the last one being by Kostakoglu, who looked at large cell lymphoma alone. However, you'll notice that the negative predictive value in all of these studies, not only for high tumor burden follicular lymphomas, primary mediastinal B-cell lymphomas, Hodgkin lymphomas, and other non-Hodgkin lymphomas, is quite high, indicating that when you get a negative PET scan, it usually means that you have no evidence of disease. It would be therefore very uncommon that a patient would develop recurrence after having a negative PET scan at the end of treatment. However, positive PET scans are not always reliable in patients with aggressive histology lymphomas, as you can see from the two which are outlined in yellow on the right-hand side, for primary mediastinal B-cell lymphoma alone being reported at only 32% and 41% for large cell lymphomas in the last of these studies. So it means generally that we begin to be able to rely upon the negative PET scan to indicate that a patient is in complete remission, as opposed to the positive PET scan in which patients may not develop disease progression. Shown here are results for a study that was conducted in Europe looking at patients who received ABVD followed by BCOP if the PET scan was positive. However, in this study, and the arm that I'm showing you here is the progression-free survival for those patients who had a negative end of therapy PET scan after having received ABVD. And all patients in this study received 2 cycles of ABVD. Those with negative PET2s went on to receive 4 more cycles of ABVD. And this was a study that actually randomized radiation therapy to those patients who had masses or nodes that were greater than 5 centimeters at the time of the initial diagnosis. And you can see that in these patients with advanced disease, there was absolutely no benefit of giving radiation therapy, although one might argue that those with large mediastinal masses or lymph nodes that were large, greater than 10 centimeters on the right-hand side on the lower part of this slide, appeared to have slightly worse results than the patients who had smaller mediastinal masses or smaller masses in all. However, there was no improvement by giving radiation therapy versus no further treatment. So it may indicate that we don't need to, at least in this study, give radiation therapy to those patients who achieve a negative PET scan at the end of treatment. This is the study that has been reported, a follow-up most recently in 2021 by David Strauss, in which ABVD was compared to Adcedris ABD for advanced classical Hodgkin lymphoma. And you can see on the left-hand side of the slide that progression-free survival was significantly better for those patients who received Adcedris ABD, which is on this red curve, whereas the blue curve, is the blue curve, whereas the red curve is for patients who received ABVD. One of the potential downsides is that peripheral sensory neuropathy does occur with Adcedris. Another is that G-CSF is necessary for all patients who receive this therapy, and overall survivals in this trial, at least, were very similar to that reported for ABVD. However, on the right-hand side, I want to show you the PET scan results, which were very interesting. This is the result. The blue is the result for patients who received Adcedris ABD, both those patients who had negative studies and those patients who had positive studies after 2 cycles of chemotherapy plus Adcedris, whereas the ABVD is worse in both groups. You can see that the PET2 negative patients also had worse results when they received ABVD. So it might suggest that you would want to give A plus ABD to those patients and obtain a negative PET scan. If a patient has a positive PET scan, they might still get better results if they receive A plus ABD. But this is still not optimal, and we need better treatments for those patients. This is BABD for unfavorable early stage Hodgkin lymphoma. There were 4 cohorts that were reported, this being reported from one center, 117 patients who had a median age of 32 up to 59 years of age, so less than 60. Mass was greater than 7 centimeters in 86% and greater than 10 centimeters in 27%. Extranodal disease was present in 21%, and by the German Hodgkin study group, they had advanced disease in 23%. So this was not a favorable group of patients by a number of different analyses. All of these patients received BV, ABD, and had a PET at 2 cycles, after 4, and at the end of therapy. What's important is that radiation therapy depended on the cohort, and the 4 cohorts are shown here, with the last one receiving no radiation therapy after the PET 4 was negative. And you can see that all of these curves are very, show excellent results regardless of what the cohort was, meaning that PET scan after 4 cycles of therapy that is negative in patients who receive BV AVD do not need, it appears, radiation therapy, although this was not a randomized study. These are PET outcomes for patients who have BV-based regimens for relapsed refractory Hodgkin lymphoma. And the first of these is BV followed by augmented ICE. And this group of patients also received BV followed by ICE in 2 different studies. Notice that the PET negativity was high in this particular, both groups of patients, although it appeared to be high in all of these in patients who received subsequent therapy with combinations or with BV-Nivo, even alone. Notice that the progression-free survivals were quite good for all of these patients, regardless of whether all patients were considered or the patients underwent autologous stem cell transplant. But the main focus of this is that BV has been added to a number of different regimens for relapsed refractory Hodgkin disease or Hodgkin lymphoma quite successfully. This is a result of a phase 2 study using an antibody drug conjugate known as Camidanlumab tesirine. This drug appeared to be quite effective in managing patients, and I'm showing you the results, the response according to PET scan outcomes at the most recent data that was presented by Zanzani in Lugano of 2021. The overall response rate was 66.3%, giving just this drug alone. And it appears this drug, which is an anti-CD25 antibody, appeared to be effective in managing these patients, at least as far as getting a response. The one problem that appeared to be an issue is that Guillain-Barré, or polyradiculopathy, whatever it was called at the time, appeared to be still an issue, or at least was an issue, especially in the early part of this particular study. And a few patients who received this therapy did not recover or completely resolve that particular complication of therapy. Checkpoint inhibitors have also been used along with chemotherapy or in combination with BV. This is a study that looked at older patients who received BV plus AVD. And I'm showing you this because the results are quite successful in these patients. It was sequential. So BV was given first, and then AVD in the middle, and the patients were followed with more BV after they completed the AVD. And the results for these older patients was really kind of remarkable, considering that former report that Evans had reported showed that these patients had very poor outcomes. By multivariate analysis in this particular study, only loss of instrumental activities of daily living was a prognostic feature for progression-free survival. This is a combination known as BV-Nivo. It was given as initial therapy for patients who were over the age of 60 or ABVD ineligible who had classical Hodgkin lymphoma. So we knew that MOP-like therapy was quite toxic for those people and who are over the age of 60. And with ABVD grade 4, hematologic toxicity occurred in one study in 69% of patients. So ABVD was not exactly one of those combinations that was considered successful either, although in Evans' most recent study, which I just showed you, they were able to administer it. In his previous study of 95 patients, 61 of these patients had comorbidities, 17% had geriatric syndromes, and 13% had lost their ADLs. In this particular trial that was reported by Chesson with BV-Nivo, supposedly a kinder regimen that might be considered more successful, you'll notice that the progression-free survival, unfortunately, was only about 1.5 years median. And ultimately, most of these patients will probably develop progressive disease. So although it is a tolerable regimen, it appears to be not a very successful regimen, at least as far as progression-free survival is concerned, without the administration of some kind of chemotherapy. This is nivolumab plus vinblastine for patients with untreated classical Hodgkin disease and a cumulative illness rating score, geriatric, of more than 6. This older method of evaluating patients, this has been around a very long time and was initially used in patients who did not have lymphoma, but it's been applied to patients who have lymphoma, as in this study for Hodgkin lymphoma. The study design is shown here, but notice that the progression-free survival being presented at ASH this year in 2021 was actually quite poor, and most of the patients would be developing progressive disease. Overall survival was decent. However, most of these patients the median overall survival was not reached, and it appeared to be fairly effective, at least controlling the disease, but most of these patients will develop disease progression. So nivolumab plus AVD has also been studied, and this is from the Checkmate 205 trial or 205 trial. It's a multi-center trial that looked at 51 patients. 44 of these patients completed NAVD. But one of the things I really want to point out is that the overall response rate to nivolumab was very high. The complete response rate was in the range of 20%, but the overall response rate was almost 70% when these patients received a monotherapy. They then received NAVD, and after 2 combination cycles, the overall response rate rose very dramatically. The progression-free survival is shown here, and by PET2, you can see that those who were PET negative had a result that was similar to those who had a PET positive. At the end of therapy, the PET did seem to make some difference. But I think the important point here is that nivolumab has not been approved as yet by the FDA as initial therapy for Hodgkin lymphoma. Ruxolitinib has also been combined with nivolumab. This is a JAK2 inhibitor, which is probably important in a variety of lymphomas. It is in the same vicinity as PD-L1 and PD-L2. It's on 9p24.1, and it's associated these Reed-Sternberg cells often have alterations, copy number alterations, and other mutations of this particular site. This causes increased PD-L1 and amplification of JAK2. So it makes sense that inhibiting JAK2 as well as PD-1 or PD-L1 makes some sense in combining these two particular drugs. Shown here is the waterfall plot. I think one of the things that's most interesting about this is that two of these patients who had what appeared to be partial response did not progress. So still having a positive PET scan in this type of therapy may not mean as much as you would think, just as with nivolumab as a single agent. The progression-free survival is shown here, and the overall survival here for this particular combination for relapsed or refractory Hodgkin lymphoma. Recall that even with nivo monotherapy for these patients, the overall response was 65%, and the CR initially 7%, with the median duration of response, I should say, at 8.7 months. So this might be better. We just have to see how that might turn out with a longer period of time. Realize that ruxolitinib has been approved by the FDA for GVHD myelofibrosis a long time ago, P-Vera and alopecia, a topical cream. Nivolumab and AVD have also been studied for early stage unfavorable Hodgkin lymphoma. And in this study, nivo alone achieved a very, very high response rate with a 51% complete response rate for these patients with early stage Hodgkin lymphoma, which I thought was very interesting. You find out that ultimately, after 6 cycles of therapy, the complete response rates were extraordinarily high. And of importance is the progression-free survival or event-free survival and overall survival, which are nearly 100%. For both. Pembro has also been combined with ICE for relapsed or refractory classical Hodgkin lymphoma, and shown here is the treatment design as well as the medication doses that were administered, which are fairly standard. This combination included 43 patients who enrolled on trial, 37 were evaluable for response, and one of these patients died during mobilization after having achieved a response to Pembro ICE and being mobilized for stem cell therapy. Most of these patients had received ABVD as frontline therapy. 39% had primary refractory disease, and 32% of the patients had relapsed within 1 year, all of these being considered adverse features for patients who have relapsed Hodgkin lymphoma. Shown over here is the complete response rate, and this is for Dovel score 1, 2, and 3. It was 81%. That's really achieving a very good Dovel score negativity. And there were 2 patients out of here who had a Dovel score of, one with a Dovel score of 4 and the other with a Dovel score of 5, both of which had biopsies that demonstrated non-caseating granulomas and no evidence of lymphoma. So again, these Dovel scores here that are positive or were false positive. This is the progression-free survival for these patients and the overall survival. So this was a successful regimen for those patients prior to their undergoing stem cell transplant. In addition, this study was also presented in JCO 2021 by Alison Moskowitz, who reviewed Pembro plus GVD, this being Doxil, the regimen shown here. 38% were evaluable out of this group of patients. The overall response rate was 100%. 30 of the 36 patients who were on this particular study who got there underwent autologous stem cell transplant after 2 cycles of therapy, and the progression-free survival was 100% after transplant had been completed. I don't know how we can change that very much. It'll be nice to follow these patients out since the median follow-up was only 13.5 months following stem cell transplant. And some of these patients may ultimately develop disease progression. However, this was going to be a bad risk group of patients, with about half of those patients having previously received BV and a little bit less than half of them having disease that was considered refractory. This is concomitant Pembro plus AVD that was presented at ASH this last year. It's a bit unwieldy regimen in that the way that the design of the study was that Pembro was given every 3 weeks, so that by the end of therapy, patients had received 8 cycles of Pembrolizumab, whereas ABVD was standard AVD, where the regimen was given every 2 weeks for a total of 6 cycles of therapy. 30 patients were enrolled on this particular trial, and their prognostic factors are shown here. 12 of these patients had early stage disease, with 6 of those having unfavorable presentations, and the remainder of the patients had advanced disease, 18 patients. There were very few grade 3 or 4 side effects in this particular study when Pembro was given along with AVD. And the progression-free survival is shown here, rather striking again, and the follow-up again, only 16 months for these patients. However, no one has yet died. In addition, this sequential Pembro and AVD is rather surprising. Alan presented this data again. It is an update of her data from before, in which patients received Pembrolizumab for 3 doses, and if they achieved PET negativity, they went on to receive AVD. So these patients received only 3 doses of Pembrolizumab, as opposed to the study which I showed you just before. This is 90% decline in metabolic tumor volume, and you can see that, you can see that most of these patients achieved that particular endpoint. The patient population is shown here, and these near complete metabolic responses and complete metabolic responses comprise more than 50% of the patients. This is partial metabolic response, and those patients who had bulky disease tended to be one of those patients. If they didn't have bulky disease, they tended to have a higher complete metabolic response than those who did. Shown here is the metabolic response overall, with near CMR and CR comprising, again, 19 patients. And then the key take-home is the progression-free survival, with the median follow-up now of 33 months is 100%, and the overall survival as well, 100%. This is going to be very tough to kind of improve upon, except for those patients who don't achieve that PET negativity at the end, which we are looking for. And even those patients who are positive need to be looked at with a repeat biopsy before they move forward with additional therapy. This Pembro is not yet approved for its initial therapy for Hodgkin lymphoma. CAR T therapy has also been reported. This was published in JCO 2020, and it just marks against CD30. There are other studies that are ongoing right now for EBV CAR Ts as well. Aggressive B-cell lymphomas have a number of different new drugs that have been evaluated. First, I would like to make sure that everyone understands that there are a variety of driver genes in large cell lymphoma. These are two series which looked at large B-cell lymphoma, and one that looked at primary mediastinal B-cell lymphoma, which indicates that it's a completely different disorder, and classical Hodgkin's disease, which shares many features as far as driver genes are concerned with primary mediastinal B-cell lymphoma. The MATOC study was specifically for primary mediastinal, and the other two studies for diffuse large cell lymphoma are shown here. You can see that these genes that are present in diffuse large B-cell lymphoma, they pretty much match one another, being the orange and the red, but there are no primary mediastinal genes that occur with great frequency until you get out to these groups of genes, indicating that this is a completely different disorder as far as driver genes are concerned. This one arrow points at the one gene that appears to be similar, EZH2, as far as mutation or abnormality is concerned. Also, you can see that these, however, bars are very, very similar to classical Hodgkin disease that was reported by Tiachi and only 34 patients. But nonetheless, this suggests that this disorder, primary mediastinal, is very, very similar to a classical Hodgkin lymphoma. However, we still are not certain exactly how it should be managed. These are various genetic subtypes that have been related to some of these genetic abnormalities. And you'll notice that now we are separating ABC out to be favorable or unfavorable, depending upon the particular genomic cluster to which they are assigned. In addition, there are unfavorable GCB variants as well as favorable GCB variants. So really, this classification that we use by immunohistochemistry is beginning to fade away and instead should ultimately be replaced by genomic clusters. This is data from ibrutinib R-CHOP that was reported for untreated non-GCB diffuse large B-cell lymphomas. It was 838 patients who were evaluable and were reported with advanced disease in the majority of the patients. The data is shown here with significant adverse events. And you'll notice that the event-free survival for those people who were under the age of 60 was better for the patients who received ibrutinib R-CHOP. And this is the overall survival as well for those patients who are under the age of 60. So does ibrutinib R-CHOP now, does it have to replace those patients who are under 60 by giving R-CHOP? This has not been answered yet. And one of the problems is that this was not a study that was randomized specifically for patients who were less than 60 years of age. It included patients also who were over 60 years of age. And you can see that the results were very, very similar as far as event-free survival was concerned and overall survival for those people who were over the age of 60 because of more toxicity and lower doses of therapy. At least that is what it was assumed. This was presented this year, ibrutinib R-CHOP, for non-GCB large cell lymphoma patients who were under the age of 60, that good group. And Wyndham Wilson reported that in this randomized study, these 4 clusters were analyzed by the LymphGen algorithm. And it turns out that MCD and BN2 are both, as well as N1, are predominantly ABC type, that is non-GCB types of large cell lymphomas. And you'll notice that the event-free survival for those patients who received ibrutinib, who had MCD subtype, was significantly better than for those patients who had non-GCB subtypes. So I think that's a very important finding. The event-free survival for N1s was also significantly better than for those patients who didn't have N1 subtype. Keep in mind that all of this data is for patients who are younger than the age of 60. Overall survivals were also excellent for those groups of patients. This is umbralisib plus Polytusimab, which was reported, this combination was reported in addition as a combination or as a single agent for umbralisib without bendamustine. And just showing you, this is the kind of patients who were enrolled, and the overall response rate appeared to get better once you added bendamustine to this particular combination. Ublituximab is a particular anti-CD20 antibody that binds to a specific different epitope than does rituximab, and it's engineered to enhance all variants of the Fc gamma 3A receptors or alpha receptors. Umbralisib is also an inhibitor of both PI3 kinase delta as well as casein kinase 1 epsilon. So this may be better than some of the other agents which inhibit PI3 kinase. So this happens to be the progression-free survival, however, for the combination with and without bendamustine. I'm not sure that this is necessarily a great accomplishment, but nonetheless, the response rates indicate activity. I want to go over checkpoint inhibitors, and you'll see why I brought up primary mediastinal large B-cell lymphoma as being an important different disorder. This is Keynote 170, which gave Pembrolizumab for those particular patients who had relapsed or refractory disease, and it was reported by Zenzani at ASH as a follow-up. There are now, with single-agent pembrolizumab, a number of patients who are out at a significantly long period of time, 3+ years, who have not developed disease progression. So pembrolizumab is a very important drug, not only for management of Hodgkin lymphoma, but also for primary mediastinal large B-cell lymphoma. Nivolumab plus brentuximab has been reported also for primary mediastinal large B-cell lymphoma by Zenzani in 2019, and the waterfall plot was rather impressive for that in relapsed disease. We have designed at MD Anderson Cancer Center, with the study being run by Dr. Raphael Steiner, a study called the Pacific Trial, in which we are now administering this combination of brentuximab plus nivolumab for 2 cycles of therapy. And those patients who have a response to this treatment continue on and receive that combination along with RCHP. Cycle 5 and cycle 6 for those patients will be similar to cycle 3 and 4, and then patients will receive 2 more doses of the combination of Etcedrus and nivolumab. What is really interesting is these patients will ultimately and subsequently only receive 4 cycles of RCHP, whether they have CRs or if they have PRs, they will receive 6. There are immunoconjugates that have also been reported, and these are important group of drugs. Tafasitamab is not one of them. It is an anti-CD19 drug that was combined with lenalidomide for relapsed refractory large cell lymphoma in a study known as the L-MIND. The progression-free survival was rather striking, although these patients didn't necessarily have the worst disease, but nonetheless, seeing these patients out at 12 months and even with a longer follow-up, these patients appear to be doing quite well, and many of them not progressing after having received the combination of CD19, Ricard plus lenalidomide. Recall that we thought that a long time ago that CD19 was not a good target for patients with lymphomas, but used CD20 instead to develop rituximab. This is Polytusimab, which is an anti-CD19B antibody with combination with MMAE. Keep in mind that MMAE is the same toxin that is in brentuximab. So we might expect to see similar toxicity when this drug is combined with other drugs. It was given with BR versus BR alone. There was no antibody administered because these patients were all thought to be resistant. And one of the things that was really interesting about this study is Pola-BR, although BR is not particularly a good combination for patients with relapsed large cell lymphoma. When Polytusimab was added to this particular combination for these patients, The PFS was quite strikingly different. The overall survival was also much better for those patients who received Polo plus BR. So this is the POLARIX study, one of the more significant studies that was presented at ASH 2021. It's Polytusimab plus R-CHP versus R-CHOP. And in this particular trial, the design is shown here. The patients were well balanced in both arms. There were patients who had a mixed BCL2 expression and rearrangements who were in this particular trial included. Cell of origin included GCBs as well as non-GCBs. These are the results. The 2-year progression-free survival was significantly better statistically for the POLA R-CHP group. 76.9% at 2 years versus 70%. So there was overall a 27% reduction in the relative risk of progressive disease, relapse or death versus R-CHOP. However, the overall survival rates were very, very similar. Side effects are those that are listed here in particular. They were not dramatically different between the POLA R-CHP versus the R-CHOP group, although peripheral neuropathy led the complication rate among all of these. Subsequent therapy on each arm of study is shown here, allowing that more patients develop disease progression when they receive just R-CHOP compared to those who received R-CHP. Is this a game changer? Does this actually now mean that polatuzumab vedotin plus R-CHP has become a standard of care? I think we'll have to ask that question in lieu of the overall survival benefit, which appears to be very similar. So this is a phase 1 study along Taclistamab, Tesogen, 139 patients with relapsed diffuse large B-cell lymphoma. This pyrrolobenzodiazepine is a similar drug that was given with camidanlimab that I showed you with Hodgkin lymphoma. 183 patients were enrolled, 137 with large cell lymphoma. These are the different doses of the drug that were administered. And you can see that the waterfall plot is fairly significant. Choosing doses, the complete response rate was about 22% for these patients, and the overall response rate 40%. One of the side effects that I found interesting was edema of any grade that occurred in 47% of these patients. In addition, modest neutropenia as well as thrombocytopenia, grade 3 or 4, occurred in these patients as well. Shown here are the number of patients and the different patients who were included in this particular treatment group. Most of them had a good performance status, but refractoriness to their last therapy or initial therapy was quite common in this particular group of patients. The duration of response to this particular single agent is very interesting in that the patients, if you look at all of them at different doses, it was very similar. However, those patients who had a complete response did much better than those patients who did not or had a partial remission. So this drug was reported in combination with ibrutinib in these patients who had relapsed diffuse large B-cell lymphoma. And this is the drug Lonca, as it is now known. Those patients who had complete response or partial response or stable disease received continued therapy and received ibrutinib continuously up to a year as long as they had a response. Grade 3 or 4 treatment related adverse events are shown here, as well as COVID, which surprisingly at ASH, maybe not so surprisingly, the COVID was the cause of death for a number of patients in a variety of different studies. And COVID as a particular problem for patients with hematologic disorders in general was a special focus of ASH 2021. Non-GCB and GCBs were both included in this particular trial. And interesting to me is that although ibrutinib is not known to be a drug that works very well in GCB type of lymphomas, and more important in GCB type, this has to be attributed, therefore, to the combination of both lonca and ibrutinib because it's a GCB group. There is further study is planned to increase the dosing of lonca to giving it monthly instead of as it was in the study. Zilovertamab vedotin, on the other hand, is an anti-ROR1 toxin conjugate, which is a really interesting target. It is an oncofetal protein that's expressed primarily in the embryo. It is not normally expressed in normal cells after birth, but it is found on the surface of aggressive non-Hodgkin lymphomas as well as solid tumors. It is an antibody drug conjugate using a humanized antibody with a cleavable linker and MMAE, again, similar to that which is known to be, that is used with brentuximab vedotin. It binds ZV or zilovertamab vedotin binds to ROR1, and therefore there is binding of tubulin because of this drug that is known to have the same effect in patients with Hodgkin lymphoma who received BV. The study enrolled a total of 51 patients. The subtype of patients is shown here. This was presented by Dr. Wong from our center. 29 or 30% or so had received CAR-T or NK T cell, CAR-NK studies before they received this drug. Side effects are shown here. One group on this side and another on this side. Peripheral neuropathy was one of those that occurred, of course, because of the toxin MMAE, which is known to cause that side effect. In addition, the overall response rate was fairly high for patients with diffuse large B-cell lymphoma, and the complete response rate not far behind it. This was thought to be a drug that might be useful in mantle cell lymphoma. And for those patients who had prior CAR-T cell or CAR-NK cell therapy, the complete response was 13%. So that's a very interesting data, which means that perhaps this drug should be used earlier in treatment. CAR-T cell therapy also was followed up in the, has been reported many times now in various meetings, but it was reported as a very important finding at ASH 2021. This is axicabtagene ciloleucel, this is Tesogen Liquisil, and this is lisocabtagene maraleucel. They look very similar, although the particular signals are different. Two of them use CD28A as a transmembrane protein. And you can see that the different companies that produce them have all used different, all use CD3 as being the eventual targeter for the T cell. So this is these are the differences in general between the pivotal trials for ZUMA-1, the Juliet trial, which used Tesogen Liquisil, and the Transcend study, which used Lysocell. Patients all had refractory disease in the ZUMA-1, whereas refractory or relapsed large cell lymphoma were enrolled in both the Juliet and Transcend study. This was a phase 1 trial. In this, the number of patients who were apheresed was 111, and 101 of these patients were treated. A significantly lower number were actually treated in the Juliet and the Transcend study, if you consider percentages of patients. There was no bridging therapy allowed in the ZUMA-1 data. However, 92% of the patients who underwent the Juliet or the 59% of those who underwent the Transcend study did have bridging therapy to try to get a response in those patients before they were sent to a CAR-T. The overall response rates are shown here, and the complete response rates here. It is very difficult to make direct comparisons. If you look at the overall survival and the progression-free survival of these patients, they look very, very similar. I would also like to mention that 5 out of 8 primary mediastinal patients were progressive-free in the ZUMA study, and 11 of 14 with primary mediastinal and transcend also had a response. So this is the data that was presented by Frederick Locke at ASH 2021, looking at patients who received Axi-cel, that's axicabtagene, Cytolucil versus standard of care high-dose therapy followed by auto stem cell transplant for high-risk large cell lymphomas who were in relapse within 12 months of their initial therapy or refractory to their initial treatment. The arms were fairly well balanced between the two groups. The only problem was in this study that nearly 3 times as many patients underwent Axi-cel as received standard of care because they couldn't get to standard of care. You had to have a response to therapy when you went through standard of care therapy in order to get to a transplant. So it is that delay that caused a significant difference, more than likely, in this particular trial. In this study, only 36% of the patients actually went through a transplant versus 94% of the patients who underwent Axi-cel. Shown here on the left-hand slide where I'm circling here, the event-free survival was significantly, I mean strikingly significantly different for the patients who underwent Axi-cel compared to those patients who were enrolled and then underwent platinum-based therapy in order to get to a stem cell transplant. I would have to suggest that this is a significant change and should indicate that Axi-cel now, at least, or CAR T-cell therapy should be considered as a standard of care for those patients who would be considered eligible. Patients who were older were also included in this particular trial. In this particular study, the overall survival actually became very, very similar for those patients who underwent stem cell transplant. But that's because 56% of these patients who failed stem cell transplant underwent standard of care cellular therapy. That is to say, they got Axi-cel or some other agent as part of their relapse disease after stem cell, improving the overall survival for those patients who underwent stem cell transplant. There was no group of patient who happened to have a worse outcome, depending upon whether they were double or triple hit, expressors, their age-adjusted IPI, their response to initial therapy or refractoriness, or their age. So those people who are over the age of 65 should definitely be considered for this as long as their performance status would allow them to undergo Axi-cel. Grade 3 or 4 neurotoxicity and I should say grade 3 or 4 CRS occurred in only 6% of these patients. Yes, the majority did have some kind of CRS, but advanced grade 3 or 4 CRS occurred in only 6%. Neurotoxicity occurred in 21%. So no patient died of grade 5. I should say that's grade 5 is death due to CRS. This is the data also that looked at CAR T levels associated with objective response or not. The levels were quite good for responders, not as good for non-responders, the peak, nor the area under the curve, suggesting that responders have a better, a higher area under the curve for number of CAR T cells. Complete response in standard of care was strikingly different according to the baseline diameters of the disease, whereas with Axi-cel, that particular feature didn't make any difference, which I found very interesting also, indicating that patients with bulky disease can be treated better with Axi-cel as opposed to standard of care stem cell transplant. This is a Tesogen Liquisil, which was also of some significant interest and was presented as a late-breaking abstract versus standard of care as second-line therapy. I would like you to pay particular attention to this particular part of the slide, which shows you that at least in the United States, it was 41 days median until the patients ultimately were from randomization until they were actually infused with Tesogen Liquisil. as opposed to significantly shorter period of time for those patients who underwent Axi-cel. This may mean that those patients, as you know, who are initially treated with R-CHOP therapy, who need initial treatment very quickly, do very badly at the very beginning of therapy. And those patients who are able to wait for a longer period of time do much better because their disease is more tolerable by the patient. However, ultimately, when those patients develop disease progression, those patients who progress relatively quickly are a bad group of patients. And those patients instead cannot wait to get to a transplant. So this group of patients is a very high-risk group of patients, and they should be offered Axi-cel or perhaps more quickly offered some sort of cellular therapy as opposed to going for a stem cell transplant. Event-free survival was not significantly different between this particular drug and standard of care stem cell transplant. This was for those patients who actually had a complete response, and it was better for those people who had a complete response to this particular drug. So response does make a difference ultimately. Grade 3 to 4 CRS, however, with Tesogen Liquisil occurred in 4.9%. Recall that this was a drug that was supposed to be potentially able to be administered as an outpatient. However, grade 3 to 4 CRS occurred with the same frequency nearly as it did Axi-cel, which is often administered in the hospital. Bispecific antibodies may be very soon following following approval, similar for Axi-cel. They include Modulators, Odronextamab, Epicoritamab, and Glofitamab. They are a little different in their particular design. This is given intravenously and can be administered sub-Q. Epicoritamab is rather famous as being a sub-Q administration. They all bind to CD3 in different loci, and they have CD20 as of the other binding site. These result in T-cell activation and T-cell mediated apoptosis of malignant B cells. So these are differences in those 4 different drugs that are all being investigated. I want to just point out that grade 1 to 4 CRS occurs in a number of these patients as percent of patients. All of them have some grade 1 through 4, but grade 3 to 4 is quite uncommon, suggesting that they could be administered as an outpatient. Many physicians have stressed and many investigators have stressed that these drugs could be administered potentially as an inpatient for their first cycle or two, although it's not been stressed by other investigators. So Glofitamab and Polytusimab have been combined and were reported at ASH. Another combination that's rather unique, using both an immunotoxin as well as a bispecific antibody in combination. There were different dose levels that were attempted, and the adverse events are shown here with CRS events. As I mentioned before, neutropenia being more common than you might think, and as well as other side effects as shown here. Finally, immunomodulators have been also studied in the older population in particular. Think about lenalidomide as being the lead immunomodulator. This is a prospective collection of 1,207 large cell lymphoma patients who are treated with various agents. And it was an attempt to design a simplified geriatric assessment based on 3 previously known assessments of elderly patients, putting them into 3 different groups. And the 3 different assessments that were used are shown here, one being ADL, the other instrumental activities of daily living, and the CRRSG, which I mentioned previously, these all being very old methods of evaluating patients who are older. Age also plays an important role in this particular assignment, and they are weighted all according to whether they are considered unfit or frail by these two methods of assessment. The IPI is also used to add points, and patients are separated out according to whether they are fit, unfit, or frail, but more importantly, by developing this particular classification, which is known as the Epi Classification. This was all being published by my friend Dr. Merli in Italy, looked at this and set up this as a new method of evaluating patients. It's called the Elderly Project. This is lenalidomide and rituximab that was administered to these patients who are considered frail, and was also reported, by Genie and ASH 2021, in which 65 patients received this particular regimen. The complete response rate was 27.7%. I would have thought it would have been that good, but it was in this group of patients who were considered frail and unable to receive any therapy other than simple rituximab. So suggesting that lenalidomide and rituximab could be administered together in these patients. The median and 2-year progression-free survival is 14 months and 38%, respectively. It might be something to consider in these patients who would only be otherwise eligible for rituximab. IR squared is another combination which includes ibrutinib, rituximab, and lenalidomide. It's also known as RIL for relapsed refractory diffuse large B-cell lymphoma. Interestingly, the responses were better in those patients who had, as you might expect, non-GCB with complete remissions being quite high, 41% in those who had non-GCB type of lymphoma. This is reported by Gua in 2019, and this is not too surprising that non-GCB patients had better results, since single agents, rituximab, ibrutinib, and lenalidomide appear to be better in that particular subgroup. Dr. Weston from our center conducted this trial along with the rest of us, known as the SMART START RLI plus chemotherapy, in which patients first received this combination for non-GCB large B-cell lymphoma. So this is a combination that is only using, quote, immunotherapy type treatment in order to achieve a response. 58 patients received this particular combination, the dosing shown here. Then patients received this combination at reduced doses with our CHOP or dose-adjusted EPOCH-R, as shown here. At the end of therapy, PET-CR was 95% and 5% had PR. But the PRs, there were 3 of them, were all false positive PRs because they didn't progress after therapy. This is the progression-free survival for those patients. Hopefully this paper will be published sometime in 2022. The overall survival is quite significant. One of these patients died of aspergillus early on because he had received dexamethasone, and the combination of dexamethasone and ibrutinib has been previously reported to be more associated with aspergillosis. This patient developed not only aspergilloma, but also in the brain, but also had pulmonary disease. So this combination, the idea of moving these drugs earlier into treatment, makes some sense. I would like to conclude with this. Chemotherapy choices for the initial therapy of both classical Hodgkin and large cell lymphoma are expanding because of brentuximab, polytusimab, and other drugs. PD-1 inhibitors have particular value in the therapy of both Hodgkin lymphoma and primary large B-cell lymphoma, primary mediastinal large B-cell lymphoma. CAR T-cell therapy also may have become a new standard of care for patients with aggressive lymphomas, and there are other novel active agents that are under further investigation. I want to thank CancerNet very much for this particular opportunity. I would be available to answer any kind of questions that might come up. I can be contacted at MD Anderson Cancer Center. Thank you.
Hi, everyone. Courtney DiNardo here, MD Anderson. Happy to take a half hour or so and take you through patient selection and novel therapies for acute myeloid leukemia. Here are my disclosures. And I like starting with this treatment paradigm, which I've updated over the past 2 years or so, just to remind everyone how much has changed, right? There's not just a one size fits all or two different treatment approaches for AML anymore. It's not just intensive chemotherapy or a hypomethylating agent. In our patients who are eligible for intensive chemotherapy in blue, you can see that there are important treatment considerations here. If they're core binding factor leukemia, you need to add gemtuzumab. If they're FLT3 mutated, you need to add a FLT3 inhibitor. If they're therapy related, CPX351 is the appropriate treatment option. We're looking at various different other small molecules to add to our patients eligible for intensive chemotherapy. And then in addition to stem cell transplant for many of our patients who are intermediate and then of course are high risk AML patients, we also have maintenance options, and we'll talk about that for a slide or two. And then in red are our patients ineligible for intensive chemotherapy, where we've moved far beyond azacitidine and low-dose cytarabine with combinations, primarily azacitidine and venetoclax here within the United States, although small molecules, especially some recent data on aza and ivosidenib that I'll go through that was just presented at the ASH meeting. And so we'll start with patients who are eligible for intensive chemotherapy and are newly diagnosed with AML. And I had mentioned gemtuzumab azigomycin. This is kind of not a new treatment. It's actually an old therapy that was approved back in the year 2000. So decades it has been available, but then it was actually withdrawn from the market in 2010 due to concerns about hepatotoxicity and veno-occlusive disease. It was reapproved a couple of years ago, 2017, at a lower dose, either alone or in combination with 7 and 3 for patients with CD33 positive AML, which is the vast majority of patients with AML. And so it's a pretty broad approval, but actually what I want to highlight is the fact that gemtuzumab really is synergistic and important to include in patients with favorable risk cytogenetics. So those are patients with inversion 16 or 821, what are called the core binding factor leukemias. And you can see here in panel A that those patients in blue do well overall with intensive chemotherapy, but you add gemtuzumab and you're seeing a 20% improvement in overall survival. You don't see that same benefit with intermediate patients a bit, about a 5 to 6% improvement in OS. And so it can be considered in those patients. But unfortunately, in those patients with high risk disease where you would love to see improvements, really no significant benefit there. And so in my practice, I really prioritize gemtuzumab azigomycin in combination with chemotherapy for patients with favorable risk cytogenetics. FLT3 mutations are super common, one of the two most common mutations in AML, NPM1 and FLT3. It's more common in younger patients with newly diagnosed de novo AML, often diploid cytogenetics, and the FLT3 ITD mutation in particular associated with a poor performance and poor prognosis. We know that the incorporation of a FLT3 inhibitor improves overall survival. This is data from the original RATIFY study, which confirmed that patients who received intensive chemotherapy with midostaurin do better. And especially in those patients who transition to transplant, the Kaplan-Meier curve on the right, you can see that those patients receiving midostaurin do significantly better at the time of transplant, likely because they are in a deeper remission going into transplant. So this is still the current standard of care for FLT3 mutated AML, although we did hear a press release, we haven't seen the data yet, that the Quantum First study, which is the intensive chemotherapy study with quizartinib, so a second generation, very potent FLT3 inhibitor specific for FLT3 ITD, led to a significant and clinically meaningful improvement in overall survival versus standard treatment alone. And so this is data that we have not seen yet, and we, of course, are eagerly awaiting it, but it suggests that we may have a new standard of care for our FLT3 mutated, newly diagnosed patients fit for intensive chemotherapy shortly. And I do wanted to use this slide to remind everyone to think about post-transplant maintenance with FLT3 inhibitors in patients who are FLT3 mutated going to transplant, which of course is the majority of patients. You get them into a remission, and then the goal is transplant. And this is data from the SORMAIN study, which uses 2 years of sorafenib as post-transplant maintenance. And you can see here a significant improvement in 2-year relapse-free survival in patients who are randomized to sorafenib versus placebo. There's also kind of accumulating data with gilteritinib as post-transplant maintenance from the Admiral study and others. And so I think this is a very important concept and definitely should be considered. Now, CPX-351, also called Vyxeos, is an approved therapy for patients with secondary AMLs, meaning therapy-related AML or AML with a history of MDS, or AML with an MDS-like karyotype. This was the original clinical trial. It was randomized 1-to-1 CPX-351 versus 7 and 3 for older patients who were fit for intensive chemotherapy. In purple, you can see the response rates were significantly improved in patients who were randomized to CPX-351. You're seeing composite remission rates of about 50%, and you're also seeing a third of patients, and this is an older population, remember, that's going to transplant. And not only are they going to transplant, but here in purple, again, you can see that those patients who went to transplant that had received CPX-351 have incredibly favorable overall survival for an older population with a decreased mortality as well. And so it again suggests to me that these patients are obtaining deeper remissions and then able to go to transplant and do quite well. And so CPX-351 is now the standard of care for this patient population. Now, another study that we have pioneered here at the MD Anderson is FLAG-IDA with venetoclax. This is a quite myelosuppressive regimen. It is actually for both newly diagnosed and relapsed refractory patients. The schema is shown here. We give 14 days of venetoclax in the initial induction cycle and then 7 days of venetoclax for subsequent consolidations. And it is, of course, FLAG-IDA is myelosuppressive. You add venetoclax, you see myelosuppression, but the response rates are really quite impressive. And this is updated data at ASH from our newly diagnosed population. Now we've enrolled 45 patients. You can see the composite remission rate is like 90%, and the more than 90% of patients who are responding are becoming MRD negative by flow cytometry. So these are really deep remissions that are associated with an improved overall survival. And at MD Anderson, we've compared this to our standard, which is CIA, FIA, or CLIA, kind of the 3-drug regimen. And we see using propensity score analysis that these patients are doing even better than our historical expectations, except for P53 mutated patients. So you can see on the slide on the right, those patients who are P53 mutated, which again is not very many. Most younger patients fit for intensive chemotherapy, newly diagnosed, did not have P53 mutations, but a few of them did. And those patients, while they obtained a brief remission, and many even went to transplant, these patients relapsed. And so intensive chemotherapy with venetoclax, in my opinion, is not an ideal option for P53 mutated patients. But outside of that genomic subgroup, patients are really doing quite well. And so this is, if you are at an academic center with a lot of support for your patients, I think this is a treatment worth considering. Now, I mentioned maintenance therapy. So we now, have maintenance as part of our AML treatment pathway, right? We have induction, consolidation, and then in patients who are not going to transplant, we should be thinking about maintenance instead. And this is based on the QUASAR data, which is highlighted here, that in patients who received intensive chemotherapy, but for whatever reason did not proceed to a transplant, that using oral azacitidine as a maintenance doubled overall survival and relapse-free survival. There was about almost half of the patients that were enrolled on this study had underlying still measurable residual disease, MRD by flow cytometry. And in this slide, you can see that, while patients who are MRD positive, of course, as you would expect, have shorter relapse-free survival and a decreased overall survival, oral azacitidine improved the outcomes even in MRD positive patients. And more than a third of patients who were MRD positive to start, who received oral azacitidine, were able to, transition to an MRD negative state on treatment, and suggest that we may finally, be getting to the point where we have a treatment for MRD positive patients after induction consolidation, which is really important. In ALL, of course, we have blinatumomab, we have monoclonals that are able to be those MRD erasers, and hopefully soon we will have some data to suggest that we have options for AML in the same way. Updated at ASH and EHA this past year is also some benefit looking at the genomic characteristics of patients on the oral AZA maintenance. And it's a busy slide here, but you can see just if you compare the solid lines, the solid orange to the solid blue, those are patients with mutated NPM1. And you can see a really significant benefit in overall survival and relapse-free survival in those patients who were NPM1 mutated. So it seems that those patients are deriving particular benefit with oral azacitidine. And so I think, in my NPM1 mutated patients, many of them don't go to transplant for various reasons, but also because they have more favorable disease. Oral azacitidine, I think, is a very reasonable and important thing to be thinking about. All right, so let's think now about patients who are ineligible or inappropriate for intensive chemotherapy. And in this space, azacitidine with venetoclax has really very quickly been taken over as the standard of care. In the original VLEA data is shown here, you can see significant improvements in the true CR rate, the composite remission rate. Responses happen quickly, they take about 1 month, and responses really do happen regardless of genomics and correlate with an improved overall survival. But not all patients who respond are forever cured. And so this is data looking at flow MRD, and of the patients who were in remissions, how many of them are likely to have deep flow negative remissions. And in blue are those patients who are flow negative remissions. And you can see that it does seem that maybe NPM1 mutated patients are more likely to reach this milestone, P53 less likely, but otherwise fairly equivalent in terms of demographics. And patients who are in remission who become flow negative have superior duration of remission and overall survival as shown in these blue bars along the top. And so, that's important for me because, as some patients are treated with aza-ven who maybe are unlikely to stay in a remission forever, this is important information. Are they likely to stay in a remission and a durable cure, or should we be thinking about transplant? So MRD by flow is important. The other thing that's really important in how likely a patient is to stay in a remission are the genomics. And so in this kind of panel of patients that Andrew Way in Australia and us at the MD Anderson looked at, you can see in group A are these patients who are more likely to stay in a remission for over a year. And you can see the vast majority of them, have NPM1 or IDH2 mutations. These are very sensitive patients to venetoclax combinations. Whereas patients that don't respond or have short remissions and then relapse are frequently P53 mutated or have FLT3 ITD or other signaling mutations. And so this is important also, again, because if my patient has some of these higher risk features or is flow positive, I should be thinking about a transplant. And certainly not all of our older patients, of course, are eligible for transplant, but it is something to be thinking about. And this is some original data looking at the fact that about 10% of patients on the original HMA-VEN studies did go to transplant, and those patients have done really well. So I think this is important to be thinking about. Now, there were a couple abstracts that were presented at ASH this past month, which were really quite interesting. And so this is the first of several of these real world examples looking at patients that received CPX-351 versus aza-ven in the frontline setting. And this is data you can see from 4 different academic centers: Cornell, Northwestern, Moffitt, Memorial Sloan Kettering. And they did, on first blush, show that patients receiving CPX-351 in this kind of blue Kaplan-Meier curve along the top had improved overall survival. But it was a really biased analysis in the sense that, the percentage of patients who went to transplant was very different, about 50% versus 20%. 50% of CPX-351 patients went to transplant, whereas only 20% of those receiving HMA-VEN did. And outcomes were really similar for those patients who did go to transplant or those who didn't go to transplant, which I thought was really quite interesting. And then there was a second real world outcome, which with very similar findings. This one was presented by a fellow from the University of Pennsylvania, looking at Penn data in addition to the Flatiron Health database, looking at like over 2 million patients at 800 sites, looking at patients who received CPX-351 versus Aza-Ven. And same thing, you can see that patients were more likely to be older with HMA then. They were more likely to be treated in the community, whereas CPX-351 patients are more likely to have prior MDS, given that's the approval, right? Secondary AML or therapy-related AML. And when you kind of do matching and propensity scores, and you're looking at outcomes, really outcomes are overlapping. And the most important thing shown here is that if you have a patient appropriate for transplant, you want to get them to transplant, because those are the patients that are doing the best along the top, whether they received Aza-Ven or CPX-351 and then went to transplant. And so these are retrospective analyses, and they are not answering the question of which one is better, but it does suggest to me that both are really appropriate outcomes. You're able to get deep remissions with both of these treatments, and the goal should be in patients who are eligible to take them to transplant for their best chance of a long-term remission and cure. Now, another kind of recent novel treatment combination that's really important, I think, is what was called the Agile Study. This was a phase 3 placebo-controlled study looking at ivosidenib, the IDH1 inhibitor, versus azacitidine alone for patients with IDH1 mutated AML. It was a 1-to-1 randomization. Over 140 patients were enrolled. You can see that this is an older patient population, as expected for lower intensity therapy, and IDH1 mutations in general happen in older patients. And this was the survival. So the combination of Aza-Ivo led to an overall survival of 2 years compared to 8 months with azacitidine alone, with a really obvious overall survival benefit shown here. And the remission rates with Aza-Ivo, the true CR rate is about 47%, and composite remission rate 53%. And then finally, looking at the side effects, there was about a 28% incidence of febrile neutropenia with the combination compared to 34% with azacitidine alone. So actually less neutropenic infections with the combination. And so I think, this really compares quite favorably and is a compelling frontline treatment option for our IDH1 mutated patients. Certainly here in the US, we're using azacitidine and venetoclax. And just to remind you, in a subset analysis that was presented by Dan Pollier at ASH this past year, a year ago, you can see that IDH1 mutated patients have a composite remission rate of about 66%, a true CR rate of 28%, and a median survival of 17 months. So this really compares favorably, and in places that are able to get molecular testing done in a quick turnaround, I think really is compelling that could be the frontline treatment choice. Now, on the other token, there was data of what's called the LACE-WING phase 3 study that was presented at ASH this past month as well. And that was looking at FLT3 mutated patients receiving azacitidine alone versus azacitidine gilteritinib, the FLT3 inhibitor, for newly diagnosed patients. And this was again, an older patient population. You can see most of these patients have FLT3 ITDs, many of them having large FLT3 ITDs by allelic ratio, and most patients having intermediate risk cytogenetics. And while the composite remission rate with the combination was significantly improved, you can see a 58% composite remission rate with the combination compared to 26% with Aza alone. What was interesting about this is this study was not blinded, right? It was randomized, but people knew which treatment arm they were randomized to, and there was a much higher proportion of patients in the azacitidine group, 44%, that went on to receive subsequent therapy. 28% of them received a FLT3 inhibitor, most of them gilteritinib, as shown in the yellow highlight, and these patients came off study much faster to go on to a subsequent therapy. And so while the responses were improved, The primary endpoint of the study was overall survival, and you can see here that overall survival was no different between these two arms. So this was a negative study suggesting that that the frontline treatment of FLT3 mutated patients with azacitidine and gilteritinib is not the frontline treatment strategy of choice, at least based on this study, and compare that to azacitidine and venetoclax here, which of course you have to take these comparisons with a bit of a grain of salt. These are retrospective kind of post hoc analyses of subsets, but this is the FLT3 mutated subset now from the AZA-VEN clinical trials presented by Marina Konopleva. And you can see remission rates, composite remission rates are also very favorable with azacitidine and venetoclax, with overall survival just above a year. But when you're looking specifically at the FLT3 ITD mutated patients, actually kind of the survival curves are starting to overlap, and the median survival is only about 11 to 12 months. And so to me, this suggests that as of right now, AZA-VEN for our FLT3 mutated patients is the recommended treatment, but it seems a little bit unsettling to me not to be incorporating a FLT3 inhibitor for patients with FLT3 mutated disease, especially at least FLT3 ITD mutated disease. And so I wonder if in the future we will kind of have either sequencing or combination triplet therapies to incorporate these agents, because we know FLT3 ITD is also a resistance mechanism for AZA-VEN. And so this is data from our center presented by Musa Yilmaz, showing that in our patients where we are incorporating what's called a triplet regimen with venetoclax and a FLT3 inhibitor, in these green bars, you can see improved remission rates, improved MRD negativity by FLT3 PCR, by multi-parameter flow cytometry, that MFC, with a signal that we're seeing improved overall survival. And so there is myelosuppression when putting FLT3 inhibitors and venetoclax together. But this is, I think, an important treatment strategy. And this is data also from our institution that Nick Short presented at this ASH meeting, looking specifically at azacitidine, venetoclax, and gilteritinib. About 26 patients have been enrolled in the frontline setting. About 12 to 14 patients have been enrolled. All of those patients are responding. We do see myelosuppression, so we have modified the treatment to shorten the venetoclax to 14 days, to drop the gilteritinib to 80 milligrams. And so I think, as we learn how to put these therapies together in a tolerable, effective way, this will be an effective treatment for our FLT3 mutated patients. The last genomic subset I wanted to mention are P53. So I highlighted this at the very beginning, that patients with with P53 mutations, P53 mutations did not do as well with venetoclax with intensive chemotherapy. And we're seeing the same thing here in the AZA venetoclax data, looking at patients with P53 mutations, which I've highlighted here. And while the composite remission rate, about 55 to 60% of patients are responding. So it's not that you can't get kind of a blast reduction, but it just is not corresponding and correlating with an improved overall survival. And so in those patients who are P53 mutated, the median survival is still under 6 months. However, patients with poor risk cytogenetics, high risk otherwise, who are P53 wild type, these patients are doing great, with a median survival of 23 months here. And so this analysis that was presented by Dan Pollier at ASH, suggests to me that higher risk patients by cytogenetics, absolutely AZA-VEN is appropriate, but we're still waiting for that magic bullet for patients with P53 mutations, because unfortunately, venetoclax combinations are not that. And this is one triplet regimen that is under evaluation with a therapy called magrolimab. Magro is what's listed here. It's a CD47 checkpoint inhibitor, so it's a macrophage checkpoint in combination with AZA-VEN. And this study is looking both in the frontline and in the relapse setting. And in 16 patients with frontline AML so far, we're seeing a composite remission rate of over 90%. 80% of them are true CRs. And most of these patients are P53. So I think, certainly we need a lot more data, but we're all very much hoping to have a treatment strategy effective for our patients with P53 mutations, and magrolimab and other CD47 antibodies have been proposed to be P53 agnostic and potentially showing responses in this particularly challenging group. Just a couple slides on relapsed refractory AML. Many of the kind of things are similar to what we talked about with newly diagnosed AML, but the most important thing to remember when you are dealing with a relapsed leukemia patient is to make sure you have done repeat genomic analysis, because you should not assume that the patient has the same genomic characteristics that they did at diagnosis, especially if they've had treatment with targeted therapies, right? A FLT3 mutated patient that's gotten a FLT3 inhibitor, there's a decent 30 to 40% chance at relapse they don't have a FLT3 mutation anymore, or they could have acquired a FLT3 mutation if they're receiving HMA ven, since that's a resistance mechanism. So just make sure that you've done your genomic analysis so you really have identified the best treatment option for your patient. There was updated data at ASH this past year of ven with gilteritinib, so the oral doublet of venetoclax with the FLT3 inhibitor gilteritinib. There are now over 50 patients that have been enrolled. Most of the patients have received a prior FLT3 inhibitor, so this is a very high-risk relapsed population. And you can see the marrow complete remission rate is about 70 to 80%. So patients are clearing their leukemia burden, but this is, even though it's 2 oral therapies, quite myelosuppressive. And so many of these responses are what we call leukemia-free state or morphologic leukemia-free state. So we've cleared the leukemia, but the counts haven't recovered. And that's that kind of royal blue color in all of these bars. We do see that patients who are able to transition to transplant, which was a decent number. So in purple, 17 patients went to transplant, and those patients have done really well. And so this does seem to get relapsed patients into a nice kind of a deep early remission, able to transition them to a transplant. And I think this is a very appropriate thing to consider as more data is developing for our relapsed FLT3 patients, especially if we're able to kind of get them to that curative transplant. And finally, there is a completely new class of treatment that I think we're going to be hearing more and more about in the coming years. These are called the Menin Inhibitors, and they are particularly relevant for patients who have MLL rearranged, what's now called KMT2A rearranged leukemias, as well as NPM1 mutations. These are genes that have mutations that have upregulation of the HOXA program, and menin inhibitors really work to help to lead to differentiation of the leukemic clone. And data from one of these menin inhibitors from Syndax called SNDX-5613 has presented data of over 50 patients now that have been enrolled, the majority of them with MLL rearrangements, showing a composite remission rate of about 40% in a very high-risk population. Patients with relapsed MLL rearranged leukemias are particularly challenging. So this was an exciting study to have seen some preliminary data on, and suggests that kind of we may have a new treatment class of hopefully effective options for us in the future. And so I want to thank you so much for your attention as I took you on kind of this tour of novel therapies and treatment programs for our patients with AML. Thank you so much.
We'd like to thank you for joining this whole program today. We trust all 3 lectures have been valuable to you in myeloma and lymphoma and leukemia as we care for our patients in an ever-changing world of hematologic malignancies. Thank you again for joining.